Hello, everyone. Welcome to Ask Your Liver Doctor's webinar series. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. We are a California-based 501c3 nonprofit patient advocacy organization and represent millions of liver patients in California. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host community and patient-centered educational programs. In addition to tonight's webinar, we will host another educational webinar in August 20th on hepatitis B. To register, please visit our website, liverhealthfoundations.org. Tonight's webinar is about LAL-D, or lysosomal acid lipase deficiency. This is a rare disease that we don't hear much about, so tonight is a great opportunity to hear from our expert physicians about this disease. By hosting these free webinars, we help raise awareness of various forms of liver diseases and provide accurate and timely information to all. Please remember, information given by our expert is not a substitute for advice given by your own physician or healthcare provider. We do not endorse any medication or treatment. Now to tonight's exclusive sponsor, Alexion. Alexion Pharmaceutical is the exclusive sponsor of tonight's program. Alexion, thank you so much for your support of our efforts. I am pleased to introduce Ms. Christy Bacon, Alexion representative tonight. Ms. Bacon is the National Thought Leader Liaison for the Metabolic Division at Alexion AstraZeneca Rare Disease, supporting LAL-D. Ms. Bacon has over 25 years of industry experience and has been with Alexion for 12 years. Ms. Bacon, welcome. Would you please tell us a little bit more about Alexion AstraZeneca and your work in the rare disease space?
Thank you so much. Hello, everyone. It is an honor to be joining you virtually today. And on behalf of everyone at Alexion, I really want to extend a heartfelt thank you to Farah and the Liver Health Foundation for bringing this entire community together, and to each of you for being here. As Farah shared, my name is Christy Bacon. I am the National Thought Leader Liaison for LAL-D, and I have had the honor in championing this disease for over a decade. Today is so much more than a webinar. It's a space for everyone to connect, to learn, and for strength. It's where patients and caregivers, clinicians, and advocates come together with a shared purpose, and Alexion is proud to be here with everybody. At Alexion, our commitment to the LAL-D community is deeply personal. We understand that behind every diagnosis is a person, a family, and a story. We are continuously inspired by the resilience, the courage, and the advocacy we see in all of you, patients and providers alike. If anyone has any questions for Alexion, please feel free to reach out. My contact information is in the chat, as well as our patient advocacy lead, Amanda Phillips Foster. Her contact is there as well. And then Farah can always put you in touch with me also. So with that, thank you so much again to the Liver Health Foundation, and I know I'm looking forward to today's session.
Thank you so much, Ms. Bacon. We are really proud to have you and Alexion's support. Now it is my absolute honor and pleasure to welcome back Dr. Ruud Coley, our distinguished presenter tonight. Dr. Coley has been a great friend of the Liver Health Foundation over the years and has supported our efforts in raising awareness of liver disease and bringing updated information to you. Dr. Ruud Coley, MBBS, MS, is the Chief Division of Gastroenterology, Hepatology, Nutrition, Associate Director, the Saban Research Institute, Associate Chair in Liver and Intestinal Research at Children's Hospital, Los Angeles, Professor, Pediatrics, Clinical Scholar at the Keck School of Medicine, University of Southern California. Dr. Coley's research work has focused on the pathogenesis of obesity, related liver diseases, MASLD. His lab has specifically investigated the role of bile acid signaling as a mechanism for MASLD and regulations of the extreme stage of this disease known as MASH. He has published more than 160 peer-reviewed articles, including prestigious scientific journals such as Nature, Nature Review, the Journal of Biology, Chemistry, Gastroenterology, Hepatology, Journal of Pediatrics, and the American Journal of Physiology. Dr. Coley is the recipient of the 2007 George Ferry Young Investigator Award for the Children's Digestive Health and Nutrition Foundation, a fellowship award from the American Association for the Study of Liver Diseases, AASLD, Takeda Research Innovation Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Foundation. Dr. Coley is a member of the American Pediatric Society, National Academy of Medicine in India, and Liver Health Foundation's Medical Advisory Council. We were proud to have acknowledged Dr. Coley's distinguished and exceptional service to our community and liver patients by offering him Liver Health Foundation's 2022 Healthcare Visionary Award, a recognition that was well-deserved and still is well-deserved. Dr. Coley, thank you for your continued support. We are ready for your presentation.
Thank you so much, Farah. This is just so much fun to put together this talk and speak to things that are close to my heart. Let me share my screen and please make it a point to have a shorter introduction if I ever get invited back to. We need to focus on the disease and what we're talking about. So, of course, I'm at Children's Hospital Los Angeles, and we're celebrating our 125th years this year. Hopefully you can see my slides and already been introduced. Today's topic is, of course, introduced as well. Here are a few of my disclosures. I'll keep that open for a few seconds. I have in the past, this is not an active disclosure, but received consultancy payments from Synergiva, which was the original company that worked on a potential treatment for and now treatment approved for lysosomal acid lipase deficiency and now Alexion, but currently I do not receive any funds from either of them. So just to give an overview first of the talk today, we'll start with just basics of lysosomal acid lipase deficiency, or LAL-D, as we like to call it for short, and then come to the organ which is most enamoring to me. I think of it as the most important organ in the body. Other people may disagree. We'll talk about liver and lysosomal acid lipase deficiency. And then finally, much more concrete as to what we can do today. And I'd love to hear questions, and Ms. Farah will be introducing Dr. Raff at the end from Seattle, and we really would like to hear his expertise as well. He's been instrumental in highlighting a couple of things that I'll share at the end about what we can do today in practical medical care. So in terms of this entity, LAL, lysosomal, meaning inside the lysosome, which is an organelle inside most somatic cells, and then acid lipase, meaning there is a biochemical process that is hastened, a lipolysis that is hastened by this enzyme, lysosomal acid lipase. If you do not have that, specifically inherited as a autosomal recessive, meaning both parents carrying at least one hit on that same gene, or have complementary hits to different parts of the gene that cumulatively in the child or the individual that inherits both hits gets a disease such as causing marked accumulation of lysosomal cholesterol, specifically lipids such as cholesterol esters. We'll go over them more in detail, acronymized here as CE, and triglycerides. A lot of you may have heard of that. That's a form of, again, lipid, neutral lipid being stored in liver cells, acronymized here as TG. a few decades ago, before this more succinct acronym LAL-D was coined, we used to call the presentation of this deficiency in its most severe and devastating form in infancy as Wolman disease. In older children or adults, if this less morbid condition was picked up, because of course the same enzyme deficiency can present in a much more variegated form. We called it cholesterol ester, coming from the CE storage disease in adults and children. Whichever format we would present with, the early infantile, some people now are calling it EO or early onset versus late onset or CESD type of LAL-D. Early onset or late onset LAL-D, both are caused by defects in the same gene called the LIPA gene. And regardless of the age of onset, the gene defect will cause liver injury, which can progress to cirrhosis and liver failure. Of course, in the early onset variety, which is the term I'm going to use now going forward versus late onset, in the early onset, you can have a presentation which is catastrophic liver failure as an infant. And of course, there are accumulative effects on cardiac, and of course, mortality is a real near and present danger, both for the early onset and slower but more progressive disease in the late onset. So let's talk about the spectrum a little bit more in definition. When we're talking about the early onset in infancy, we're seeing liver failure within 12 months of life. In children, you may pick up the child in a well-care visit in your pediatric office or family practice office with enlarged liver and spleen, or at 9 or 10 years of age when the first cholesterol screening tests are done by the American Academy of Pediatrics guidelines. Elevated liver test and or elevated cholesterol may be picked up, along with potentially slowing down of a growth spurt or the absence of the normal growth spurt. In adults, we will see mostly pickups from liver clinics or clinics where we are measuring cholesterol, such as primary practice and or cardiology clinics. And of course, early onset cardiovascular disease from this high levels of cholesterol, and we'll go over the types of cholesterol. Unfortunately, it's not the good kind, leading to atherosclerotic disease. So regardless of this, the question becomes, is this really present? We're talking about something in the absence of data. So let's share some data here. That's the conceptual form of the disease, but then who does it afflict? When we look at European ancestry, we're talking about 3 to 6, the best approximation, in 1 million births. However, if you flip that around, that's about 1 in 160 to 290,000 children or adults. So this is very, I would say, conceptual, because it's hard to wrap, at least for me, hard to wrap my brain around this number. And I'll go over some different ways of looking at this number as we get closer to the what we can do set of the slides, especially in certain very well circumscribed populations that unfortunately may be at higher risk. And the age distribution, of course, the early onset form will be, as its name suggests, be present early. So we're looking at about, and again, these are the ones that we identify, and I will submit that my opinion and one person's thought that we are under identifying these children and adults that are suffering from LAL-D. About 20% of those who we do identify, we pick up under 2 years of age. There's a big chunk, about 60% or so, that we pick up between 2 to 12 years of age, and then the kind of tail is very long, all the way up to older than 60-year-olds have been picked up with LAL deficiency. The mortality is rapid, especially in the early onset LAL-D disease, and you can see data here where we can, as a Kaplan-Meier curve, on the x-axis going from 0 to 12 months, and the survival probability is really, really scary. And growth failure on the older side, we were talking about, again, the survival probability hits hard. Liver progression in LAL-D is also rapid. And here's a graph in pediatric and adults, when the first time you identify the individual and you follow them for 5 years, how long will they be in the orange bar here, solid, event-free? And you can see that very quickly within the first year, you're down to about 60-odd%, and it rapidly continues to afflict individuals. You are not event-free from a liver perspective. Fibrosis, cirrhosis, or liver transplant really is a common entity. When you go into what is going on inside the cell, and I promise you I won't spend too much time on this, but just follow the arrows with me for a second. And then we started the discussion around the lysosome, this circumscribed area in the middle of the cell, if you can see my arrow. And what you see is you're accumulating these CEs, as I talked about, and accumulating these triglycerides, meaning to say, in the absence, and normally we don't do that, the red arrows point towards where there is a normal response when your fatty acids are coming in or free cholesterol is coming in, you will try to modulate how much triglyceride or cholesterol ester you keep inside the lysosome and how much you export out into the circulation. The problem is, in the absence of lysosomal acid lipase, you start to accumulate these TGs and CEs. The mutations themselves, we do not have a phenotype-genotype correlation available, meaning this particular mutation is known to be so high risk for mortality or so forth. However, the loss of function mutations do seem to be rearing their head more than other kinds of mutations. When you have this deficiency and you start to accumulate, you can see those blue balls inside the lysosome rather, accumulating as depicting triglycerides, and the green ones depicting cholesterol ester. Now we start to see, unfortunately, a lot more damage with these larger lysosomes. Under a light microscope, if you had ever done a liver biopsy on an individual with CESD or late onset LAL-D, you would start to see these shiny crystals or cholesterol esters kind of show up. When we talk about specific individual organ systems that are affected, I will pay a little bit of attention to the heart as well, not just to the liver. But 87% of patients with LAL-D will have cardiovascular manifestations. As you could imagine, when you have dyslipidemia, when you have elevated bad or LDL cholesterol and low good or HDL cholesterol, there are consequences of coronary artery disease coming from atherosclerosis. And in the brain, you could also have similar stroke. And of course, the heart attack, myocardial infarction risk is right there in front of us. Spleen, which is an organ less talked about a lot of times, sitting on the left side of our body, when we start to have accumulation of these abnormal lipids, they don't differentiate. They accumulate in the coronary arteries of the heart, they accumulate in the liver cells, as we'll talk about in a second, but they also accumulate within the spleen, and you're starting to see larger spleens. And the job of the spleen is typically to maintain a good cadence of taking back cells, especially white cells and platelets that are no longer viable. So when they age out, they're kind of the graveyard of the cells is the spleen. However, when your graveyard gets to be too big, you are going to start to look for individuals who may not have reached maturity. And so white cells and platelets get absorbed even more so into the spleen, unable to get out, extricate themselves, and end up in what we call hypersplenism, or a manifestation of low white cells, or leukopenia, and low platelets, or thrombocytopenia, and associated disorders with anemia as well. And of course, some consequences if you get injuries. Inside the GI tract, you will have accumulation of lipids when you have such endoscopic views, as you can see in this picture here, with lumpy, bumpy, lipid-filled intestinal villi. You're going to have a problem in the normal functioning of these villi of the intestine, which is to absorb nutrients. So you're going to have failure to thrive and growth failure. You're going to have diarrhea because there's going to be more malabsorption. And of course, if this manifestations irritate the stomach lining and so forth, that you can have nausea and vomiting as well. So when you think about LAL-D as a life-threatening genetic disease, I think the consequences are the most important that we have to think about. And when we talk about the most important consequences, as I said, I am biased, we have to think about the liver. The liver gets bigger, just like the spleen does with the accumulation of these lipids. There is inherent injury to the liver because the liver doesn't like to be filled up with lipids. There is, some house guests you may like, but these house guests, the liver hepatocytes, the liver cells do not like, and they end up having inflammatory consequences, a reaction to those house guests. And when you have these inflammatory consequences, there is damage to the hepatocytes and there is leakage of normal liver enzymes, ALT and AST. Some people call them SGPT, SGOT, but suffice it to say, we have injury ongoing. And when you have ongoing repetitive injury to a place, what happens? If I were to cut my skin over and over again, and even with the tiniest of scalpels at the same exact spot, it will scar. And that's what happens inside the liver. You start to lay down collagen, fibrosis, which of course manifests in the long run with an entity that most of us have heard of called cirrhosis. That in and of itself, a shrunken, lumpy, bumpy liver, is harder for blood to flow through, so you create high blood pressure systems in that. And because the portal area is the main entry point into the liver, we call it portal hypertension, not to be confused with regular high blood pressure or systemic hypertension. And unfortunately, in some infants, this can move so fast, like we saw within 12 months of age, you have liver failure and death. We talked about the heart, the spleen, and the intestine already. So that's the overview of LAL-D. Now let's go deeper into what I've just started to talk about, which is the liver in LAL-D. You can see this abnormal looking, this beautiful organ, which, every triangle to me is a liver until proven otherwise. This does not look like a nice pink homogeneous triangle. This looks like a lumpy, bumpy, shrunken liver, and that's not good. It's a cirrhotic liver from a patient with lysosomal acid lipase deficiency. 50% of the individuals who have died from liver disease, unfortunately, do as a pediatric age group, under 21 years of age. So therefore, for me as a pediatrician, as a pediatric pediatrician interested in children with liver disease to help them, this becomes an important diagnosis even more so. The progression, if one may be able to look at these slides from left to right, you're seeing the accumulation of lipids, these white holes that my arrow is pointing towards inside each of these circumscribed pink lines is a nice liver cell, but unfortunately it's filled with those house guests that we do not want, lipid, cholesterol ester, or triglyceride particles, and they're fluffy. They're small particles. They're not like a big blob of white and pushing the nucleus to the side. Why I say that? Because those are the two descriptions of microvesicular versus macrovesicular steatosis, or fat accumulation, as we call it. So steatosis was evident in 87% of these patients in this study with LAL-D and liver disease. Fibrosis, which is scar tissue shown in blue here, was present in half of them, and cirrhosis, 5 out of 31, 16%, of which, of course, then 6 went on to have liver transplantation. So there are other things that can cause such presentations. Most commonly, now we call this fatty liver disease is no longer called NAFLD or NASH, but it's called MASLD, metabolic dysfunction associated steatotic liver disease. Try to say that fast 5 times really quickly. But there you will find macrovesicular steatosis for the most part. If we did a liver biopsy, as I just described, in LAL-D patients, you would see micro. But again, when we get to the section, which is probably the most important, what can we do? I'll try to discern that this difference is fluid. You may have individuals that have mixed both micro and macro steatosis. And again, the liver biopsy may not be something that we do all the time for all individuals, but just keep an eye on these other causes of steatosis, because these become a differential diagnosis for lysosomal acid lipase deficiency, where we are seeing dyslipidemia, just like we see in NAFLD, NASH, or obesity or diabetes, and steatosis in the liver. So this was the differential that I was trying to present to you. You can see those small, tiny vacuoles here, which is microvesicular, and large vacuoles of lipid white globs here that push the blue nucleus to the side, whereas here you can see the nuclei are very much dead center almost inside the liver cells individually. So that's the big differential between the two. And here's the more high power views of those changes. You've got the macrophages, which are a different style of mop-up cell of inflammation that they come in. We've got these blue dots here, which are the inflammatory T and B cells that are coming to help with the fight against these house guests that I was talking about. And of course, the scarring here shown in red fibers instead of blue. It depends on the type of stain you use on the histology. So MASLD guidelines now, the European societies, the North American societies for children, when they talk about looking for fatty liver disease, which is unfortunately, or MASLD, as I was saying, it's now called, the most common cause of liver disease in children, afflicting, depending on which population you're looking at, almost a fifth of our children are now overweight or obese. And within that population, very highly enriched, you will have high prevalence of children with fatty liver disease. When you're thinking of a child who is obese or overweight and has elevated liver tests in the blood, in the differential diagnosis, there's a whole list of things that can be causing that. Yes, of course, the number one is going to be obesity. However, just because a fifth of the population has weight that is above normal does not mean they cannot have other diseases. My mantra has always been, let's not differentiate, let's not discriminate, maybe a harsh word, against individuals who are living in larger bodies, and they can still have other diseases like citrin deficiency, Wilson's disease, and lysosomal acid lipase deficiency. So we should be paying due respect to the workup of these children. When you look at elevated bad LDL cholesterol, it sometimes can help distinguish in patients with and without MASLD. So you can see this patient's curve here in maroon red. 79% of LAL-D patients had that, but it's a difference which has to be discerned. 20% versus 79%, but there still are going to be children who have dyslipidemia or obesity. So it's not an all or none phenomenon. What I will say, and I'll make this point again in the last section, is that when you do counsel children for fatty liver disease, like you should, with diet and exercise changes, they show up in your clinic again with weight loss, but their liver tests have not improved and their LDL-C has not improved. That's when we're thinking about other causes as well, a secondary workup. That's where lysosomal lipase deficiency should be top of mind, not an afterthought anymore. So just to contrast, one of the other things we should be thinking about in that scenario is Wilson's disease. And Wilson's prevalence is coded at 1 to 30 to 1 to 70,000. It's more, relatively speaking, common than lysosomal acid lipase, especially as the literature suggests, but not in specific populations. I will talk about again in a second about those specific populations. So rule out LAL-D when considering other lysosomal storage disorders as well. Niemann-Pick and Gaucher's, I will not be going into detail on either of them today, but suffice it to say, when you have a child coming in with organomegaly, those three are conditions you will be thinking about. So who are the patients we should be testing? Who have progressive liver disease of unknown cause, when you're thinking about MASLD, when you have an elevated liver test or LDL cholesterol. So that's a summary for the liver perspective, but the final section, which I've been talking about all evening, let's get into it. What can we do today? So when we think about LAL-D, there's two eras, before we had treatment and after we have treatment. And sibulipase alpha, a recombinant form of the human lysosomal acid lipase, is available now to treat lysosomal acid lipase deficiency. It is an enzyme replacement therapy. The production and mechanism of action of sibulipase alpha, I'm not going to go into, but what we think about is the usage of sibulipase alpha in individuals with LAL-D. And this led to a series of trials which culminated in this phase 3 trial of enzyme replacement therapy in both children and adults. There were 66 patients, and what they were able to showcase is such a beautiful graph. One would hope to have treatments such as this for any and every liver disease, at least in my purview, for children, where you have a child who is in treatment versus, you can see here in blue, As soon as we started sibulipase alpha, within 4 weeks, their ALT, their liver enzyme marker in blood, is coming down almost to 50, 60 ALT compared to below where it was there. So a drop of 50, 60 points, which in most cases is going to bring it into the normal range, depending on where they started. Versus when they were getting placebo, no change. Half of the patients were divided during the double-blind initial 22 weeks versus open label period when everybody got sibulipase alpha and everybody's enzymes got better. Such a clear night and day answer. There's no statistics required. My professor once, when I was doing my master's in clinical investigation, used to say, you need statistics, but yes, this is a statistic professor. He said, you need statistics, yes, but if you can see the answer, sometimes statistics are just going to support your answer. That's one of those places where you can see the answer. ALT normalization, clearly 0.027, he was right. And there were other criteria where they were looking for significance, and you can see there's a decrease in LDL cholesterol, non-HDL cholesterol, AST is another liver enzyme normalization, increase in the good cholesterol, HDL, liver fat reduction, liver size reduction. I can go on and on. The smaller subset of patients with biopsies available had shown all of the individuals in the study had fibrosis. 50% had bridging or significant fibrosis, stage 3 or 4 ISHAC scoring. Again, not going into details of that. And a third had cirrhosis, the final stage of liver disease for most chronic liver disease conditions. So when you look at safety, not a lot of SAEs that are listed here. About 5-6% had to be treated with an anti-drug antibody at one time point with no safety or efficacy changes. Let's summarize and distill all this together. I'll leave you with 3 points. When you're searching for patients, now that we have a treatment, you've understood how it affects the overall scenario and specifically liver patients, I would leave you with these 3 points. Hiding in plain sight, is it one diagnosis or two, and making it worse. So what do I mean by hiding in plain sight? I alluded to this before, where you have lysosomal acid lipase deficiency hiding behind a individual, child, adult with, unfortunately, overweight, obesity, causing metabolic syndrome, diabetes, hyperlipidemia, and fatty liver disease. So this is a 19-year-old who I picked up. They had been trying to lose weight, but despite losing a good number of pounds, they did not have any improvement in their liver enzymes. When we did an ultrasound for them, we saw splenomegaly. When we worked them up further with a liver biopsy, and then subsequently with a LAL enzyme assay and genetic analysis, it all lined up. Microvesicular steatosis, inflammation. Here you can see in black and white electron microscopy images of that patient showing these lipid droplets again inside the lysozymes. So support screening because it can be hiding. Here's another way individuals can be picked up, which is in populations that have a higher prevalence. Remember, we're talking about 1 in 160,000 and above, but here I'm showing you a prevalence of 1 in 4,200. All the way back in 2011, there was a genotype frequency study done in Los Angeles, where we are today, in the Iranian Mizrahi Jewish population, Persian Jewish population, and they saw that Wolman disease is substantially enriched, unfortunately, in this population. There might be a founder effect. This was in a much bigger cohort of 500 and almost 50 individuals done by Donna Bernstein and her group, published in 2025, rapidly progressive, again, infantile. So when you're talking about the early onset disease being prevalent in a subset of our population, we should support screening. Again, hiding in plain sight. One diagnosis or two. So there's another entity which we haven't talked about much, which is hemophagocytic lymphohistiocytes, where we have, it's more of a oncological process where we have shutting down of heme processes leading to similar manifestations as what we've been talking about with early onset lysosomal acid lipase deficiency, or even late onset elevated triglycerides. On the left, I'm showing HLH, fever, cytopenias, organomegaly. On the right, I'm showing early onset LAL-D or Woolman, again, organomegaly, high triglyceride numbers. There are subtle differences, maybe, but what we have seen now published across multiple reports, including what Dr. Raff will share of his experience, is that you can start to see both in the same patient. Or maybe there's a chicken and egg here. And here the X-ray is showing some calcifications in the adrenal glands, which is more specific for Wolman's disease. But the question is, when we have a treatment available with enzyme replacement therapy, ERT with sibilipase alpha, should we start to treat if there are signs of lysosomal acid lipase deficiency, whether it is the primary cause or the secondary cause, whether HLH leads to LAL deficiency or LAL deficiency is a secondary cause of HLH? We have not been able to discern as a scientific community, but definitely there are case reports showing treatment with ERT can be life-saving if initiated early. And then the flip side of this is, can LAL deficiency be making other chronic liver diseases worse? We know something called synergistic heterozygosity, where you have a half of a hit against yourself. You don't have true LAL deficiency, but you have low LAL activity. We see it to be more prevalent in individuals with cirrhosis, with cause neutral or unknown or cryptogenic cirrhosis, or cirrhosis of known etiologies. Both scenarios, we've seen LAL activity to be lower. Is this, again, correlation, causation? We're not sure. But to question this, to understand this, is the need of the hour. So in terms of conclusions, and I'll stop right after this, LAL-D can be diagnosed both early onset and late onset. We understand there are some special populations. So there's individuals who are overweight where it may be hiding. There are populations where there may be increased risk, all the way going down from 1 in 160,000 all the way down to 1 in 2,400 and lower. We should be screening. And then treatment is available. It improves dyslipidemia, reduces liver fat content, decreases morbidity and mortality, both atherosclerosis and liver transplant related. So we need to, once identified, treat early. So I will stop here, and thank you so much for your attention.
Thank you so much, Dr. Coley. This was an excellent presentation and information. We appreciate it. Thank you. Now, before we start oh, I'm sorry, I'm losing my contact. Okay. Now, before we start our roundtable session, which we're going to start in a few seconds, I want to introduce our guest, Dr. Michael Ruff. Dr. Michael Ruff is MD, FACMG. He is a clinical geneticist and a clinical biochemical geneticist at Multicare Health System. It's based in Tacoma, Washington. He's also medical director of genetics at Mary Bridge Children's Hospital and the Multicare Cancer Institute in Tacoma, Washington. His practice includes metabolic liver diseases and lysosomal storage diseases. Dr. Rao, welcome back. We truly appreciate your support and being here tonight.
Yeah, thank you, Farah. I just want to say I really enjoyed Dr. Coley's talk. You know, I'm familiar with LAL-D, but it's always wonderful to hear an expert explain it using wonderful language. And I'm going to borrow the concept of unwanted house guests for for the bad cholesterol and the triglycerides and all the other evil humors that we want to avoid. So that's an excellent analogy. Consider it borrowed. And then also your discussion of LAL-D and the enzyme, the LAL enzyme, and how it may play a role in other areas related, like cirrhosis and all that. Absolutely fascinating. And maybe there's so much more we can do with the treatments that are available. I'll just go ahead and say I'm fortunate and unfortunate at the same time to have experience with, as we were hearing about, the severe early onset infantile form of LAL-D, often known as Wolman disease. And exactly as Dr. Coley has said, it is a terrible disease without treatment. It is lethal. You know, these infants do not survive. And before we had treatment, there was only so much you could do. People would try transplants, bone marrow, liver, wouldn't save their lives. Whereas the case I was involved in was, if you were going to have Wolman disease, it was well timed because this little child was doing very badly. By 2 months of age, it was looking like he wasn't going to make it. Fortunately, we were still trying to figure out what was going on. He developed HLH, which we were hearing about from Dr. Coley, the hemophagocytic lymphohistiocytosis. And it took years of training for me to learn to be able to say that. So I still go back to saying HLH. And there, HLH can be caused by many things, and it can be caused by nothing. But it is a hint, if you have HLH in an infant, to think about LAL-D, this severe form. And that's what made us think about it in this child a few years ago. We sent the enzyme test, just as Dr. Coley has described he did in some of his patients. It was positive, and the drug Cibalipase alpha that we were hearing about wasn't yet approved. It was nearing approval, and reaching out to Alexion, they were able to, with an arrangement approved by the FDA, provide the drug. We gave the drug to this child, and it saved his life. And so he's alive now. I think he's like 9 or 10 years old. And he's alive because the diagnosis was made in time and the treatment was made available to him. And it's remarkable. So this is a rare disease that we don't want to miss. And even though, yes, it's a rare disease, as Dr. Coley was also saying, it's incumbent on us to diagnose rare diseases that have treatment. We need to do it. It's not enough to say, oh, it's rare, I don't need to try to diagnose it. Of course we do. Of course we do. And we need to treat. And I also, as Dr. Coley also said, you'll notice anything I say, Dr. Coley beat me to it. It's probably more prevalent than we think. And the recent literature in the last few years that we just heard about of finding LAL-D pathogenic variants mutations in the Mizrahi Jewish population is a lesson to us. We're missing cases right there in the diaspora in the LA area. We don't want to miss those. We can save those lives. So there's so much still to be done. And with the help of entities like the Liver Health Foundation, we get the word out, we spread the word. Dr. Coley spreads the word too. So these are wonderful times in that there's now something we can do for these terrible diseases. So that's my experience with an infant and with a child. And then, of course, Dr. Coley shared some of his experience with adults. It's out there. We can treat it. Let's keep spreading the word.
We have a question in the chat I want to ask both of you doctors, please. It says, what does one do if their LAL activity is above the established affected range, but is below the unaffected range?
So if I understand correctly, we're talking about someone who has a readout from one of the commercial labs, probably. Some of them have started to give normal, just below, and then abnormal. So they are putting in a gray area. It has lent itself to some questions, even in clinic. I don't know if Dr. Raff has had to face those as well. And my processing of that has been what I'll answer with, which is happy to sit down with medical genetics, refer over to medical genetics to do formal consultation, and then if the family agrees, to send off genetic testing. However, if that is something they do not want to pursue for a final answer, I can give them a gestalt that you're probably a carrier, and you may have some higher propensity of liver and potentially other organ damage. We're talking to a liver specialist, I'll talk about liver, if you have other liver diseases. So for adults, I would counsel them to stay away from alcohol, excessive use. If you're a child, to maintain good BMI so that in adults, so that you're avoiding high fructose containing drinks and sugar sweetened beverages and so forth. So common sense things, get your Hep A vaccine, Hep B vaccine, common sense things to protect your liver is where I would advise them typically.
Dr. Raff?
Absolutely. There's very little I can add to that. I'll just say if you were testing a very ill infant with HLH, that would mean it's not Wolman disease because you should have negligible enzyme activity. But for the later onset cases, which can still be pretty severe, I think Dr. Coley's answer is right on. You would do genetic testing to clarify, and then very good advice that we just heard.
Okay. So one of the questions that has come in was, how is research into treatment and cures advancing? Dr. Coley talked about that. Is there anything new that patients and their families need to know?
Dr. Raff, I don't know if you want to speak to rapid whole genome and the impact that's having on your field.
I can address that part, but I leave the rest of the research world to you. So yes, we heard that the diagnostic test is enzymology, doing the enzyme test, which is easily done on a blood spot or a small tube of blood, and that's great if you know exactly that you want to test it. But one of the things that is very beneficial to diagnosing rare diseases, LAL-D and others, is that we're now in the era where we can do whole genome and its cousin, whole exome sequencing. So if we think, oh, this is a very sick individual, this might be a genetic disorder, it seems like it, I'm not sure which one, I can't remember, there's so many, I don't want to miss the diagnosis. So you say, let's sequence the genes, let's see what we have, and LAL-D can be diagnosed that way. So if you do a gene panel for cholestatic liver disease, the LAL-D gene is in that panel, and it should find a pathogenic variant and say, hey, we think we have a diagnosis here. And then it goes to people like Dr. Coley to say, yeah, I agree with that. I don't see anything else. I think that's the primary explanation. Let's treat this.
No, I agree. I think that's the biggest change, which is that we have more tools than any that I presented, historically speaking, to diagnose individuals. And when we have such sick children in early onset, it's a life or death situation where if we can pick something up with rapid whole genome under a week, there is some talk, some murmurs about some in certain states to think about adding lipogene or the DBS spot into newborn screening. Not anything active yet, as far as I know. And maybe Miss Christy Bacon can enlighten us afterwards if there's any other information she has on that newborn screening aspect. But the two things I mentioned at the end, which I would love for there to be more research, is the point about overlapping with HLH, whether or not this is secondary HLH or is this a consequence of HLH. And the same question, the chicken and egg question for our cirrhotic individuals. Do we get to cirrhosis more and then have deficiency of LAL-D, or having a heterozygosity in the lipogene predisposes you to more severe chronic liver disease, and hence more individuals with cirrhosis have more lysosomal acid lipase deficiency. So I love to see more work done. Unfortunately, I don't have a lot of new things to share other than the genetic screening and workup versus what we still need to do. So I'm glad that there may be some more children we can help, adults we can help if we continue along this path of research.
Next question. NAD as a supplement. This is a parent who has a teenager with LAL-D. You talked, Dr. Coley, you touched on the sugar and diet, and this person is asking how important is diet and alcohol and your young adults with LAL-D. What can we do for them?
So nicotinamide, if I'm understanding correctly, NAD is what they're asking about. There's a lot of talk in the lay world around NAD usage for usage in mitochondriopathies, for instance. There are some trials going on in that arena. I am not aware of specific trials or work done for NAD in LAL-D patients. I will say this, that now that we have the actual replacement we have a reconstituted human lysosomal acid lipase available. Doing things that are short of that seem to be counterintuitive. I'll just leave it at that.
And okay, Dr. Ralph, you want to say something on that?
I just want to add, I think this sort of gets to the fact that yes, if we can provide the missing enzyme, that's the treatment. But it's not a cure. So, you'd think, well, it's the missing enzyme, we're giving it back. Surely that solves the problem. It solves a lot of it, but not quite all of it, because we can't quite put the enzyme where it needs to be as well as nature can. So, good liver health. Whether that's you consider that NAD supplements, other supplements, not drinking, et cetera, all the good advice, still important.
What is the
Yeah,
long
I
term?
don't.
Oh, go ahead.
So
Go ahead.
I don't disagree with Dr. Raff. I think there's as a supplement, not as a primary treatment. Maybe that's where I should have been more discerning. I think as a supplement to an adjunct to the primary treatment with enzyme replacement, yes, I see low downside. However, again, I don't have strong data to support that, but I see low downside.
What is the long-term efficacy of enzyme replacement therapy for CESD?
So CESD is another way of cholesterol ester storage disease, like I described, is just a late onset version of LAL-D. Um, are they talking? What the question was more about the consequences? Is that what you were asking?
Yes, the long-term efficacy of it, of the enzyme replacement therapy.
Oh, the reversal. So in CESD, just like we've seen with Woolman's, with the early onset LAL-D variety, there is benefit directly from ERT, from enzyme replacement therapy. As I showed in the graphs from the phase 3 study with Dr. Roberts, there's dramatic reversal of liver enzyme. There is reversal of the size of the spleen, therefore you have decreased hypersplenism, and you have a improvement in the quantity or amount of fat restoring, restoring liver. All those things are reversed. And cumulatively, of course, the morbidities and long-term data is still pending. With registry data, we will hopefully be able to answer some of those questions. But we can only hope that there is a continuation of those early signs of improvement that we're seeing with the ERT.
And Dr. Rao?
Yes, unfortunately, some of my audio gave out for a portion of that, but I get the point, that the in terms of the long-term aspects, of course, we don't have long-term data. It hasn't the drug hasn't been around long enough. So how is it going to be after 10 to 20 years plus of treatment? We don't know. We don't know the long-term natural history of being on this treatment. But of course, we know it's effective. It's not a cure, and there may have been other aspects to Dr. Coley's answer that unfortunately I missed because of my audio.
Yeah,
You
I
didn't
think
miss, you
something
didn't
went
miss much.
I'm sure that's not true.
wrong. Is gene therapy being investigated? Is it going to be potentially the curative single dose treatment for LAL-D?
I'll let the geneticist answer that one.
Yeah, I don't know if anyone, Dr. Coley, you may know. I don't know if anyone's working on gene therapy for LAL-D. I'm not aware of it. But certainly lots of people have been working for many years on gene therapy for other genetic liver diseases. And there's been great progress. There have been major challenges on the way, but there's been great progress. So in terms of LAL-D, it's not going to happen anytime soon, but in the long run, who knows what's possible?
What is FH? I'm going to try to pronounce that, familial hypercholesterolemia. And why is it that it's sometimes misdiagnosed as LAL-D and vice versa?
Yeah, so you have to have a family history. Again, geneticists probably can speak better than this to have familial hypercholesterolemia. That's the one big discernment between the two. They can be confusing. There are different forms of hyperlipidemia that are inherited, and some of them will have high triglycerides, and some of them will have high LDL cholesterol. which are also the things we've been talking about with LAL-D. However, you will not have typically a family history of LAL-D. You will have a patient that presents early onset, very, very sick, or you pick up because of certain things as they get older, as we've already discussed. So the biggest difference is that, however, every child that has an elevated triglyceride is not hypertriglyceridemia from inheritance. That's the point we're trying to make. Every child that or adult that is overweight, obese, and has high LDL cholesterol is not just because of obesity. That's the point we're trying to make. Keep the thought hat on and continue to think about, especially when you are faced with limited progress. Say, for instance, now there's a whole wave of GLP-1 agonists, semaglutide, Wegovy, and so forth, Ozempic. I do not have any stock in any of those companies. But if you do take those medications and you lose weight, but you do not improve your liver enzymes,
Yeah.
or you do not improve your LDL cholesterol, that's another head scratcher, right? Or you get bariatric surgery and you lose weight, but you don't improve your liver enzymes or your cholesterol. That's another head scratcher. We have to keep our thinking hats on.
A question, and we're going to have two questions real quick because we're running out of time. But Krista from LAL-D Aware Foundation is asking, are there many patients in the West Coast? Because their organization has more contact with Midwestern and East Coast patients than they do with us in East Coast. Do you have any information on that? East Coast patient versus West Coast patients?
I really would be. I think we need more screening. As I said, the population we serve here in Los Angeles, I'm not sure in Seattle, Tacoma, the prevalence of or the epidemiology of this disease, but at least in LA, one would suspect more early onset in the population we just discussed, at-risk population we just discussed. So yeah, we probably need to spread awareness. And sorry to say, Farah, your job is very, very important in this.
Oh, thank you so much. And as you know, we are recording this program and we're going to put it on our Facebook, our social media, and also website and YouTube, so people can have access to the information. And the last question I want to ask, somebody has asked, what is the life expectancy of LAL-D patients? I heard that you said for infants, it's not very promising.
Well, that for infants, and I'll let Dr. Coley answer about the rest. Yeah, without treatment for infants, lifespan is measured in months. Many of them don't make it to a year. Full-blown Wolman syndrome, the average lifespan, those Kaplan-Meier curves that Dr. Coley showed, the average lifespan is 3.7 months, I believe. It's extremely low. But if we treat them, that's not the case. Then they will live for years, hopefully full long lives. We just don't have the full long life data yet. So it's truly life-saving. And I'll let Dr. Coley answer for all the other age groups.
Yeah, and for the late onset or CESD, as it used to be called, variety, it's again dependent on the morbidity. And we saw with one study with the 50% fibrosis and 16% going to transplant with cirrhosis, 16, 17%. And those numbers come from a total study strength of under 100. So we have to take it with a pinch of salt that unless we screen more and find more patients, we're still looking at probably at the tip of the iceberg, especially when we are talking about indeterminate levels or heterozygosity and how that affects longevity, morbidity, and mortality from other diseases. So there is the devastating form, which Dr. Raff very nicely described. Then there is the slow brewing form, CESD. And then there is this whole category, which I think I would call undiagnosed or LAL-D affected individuals, whether they have heterozygosity or other ways triggering HLH, and for instance. So there is a whole spectrum of disease here. So it's not one answer, unfortunately.
Thank you so much. This was a great conversation. I personally learned so much about LAL-D. So thank you, Dr. Coley, for your wonderful presentation and support throughout the years. You have been wonderful in helping us get the word out and participating in our webinars and in-person events. Thank you. Thank you, Dr. Raff. We appreciate your participation and contribution to this important topic. I hope to reach out to you for our future webinars as well. Thank you, Ms. Bacon and Alexia, for your support of our efforts to bring updated information to liver patients. Please join us on September 12th for liver health screening, health fair, and Walk for Your Liver Los Angeles in Santa Monica. This is our very most popular walk that we host, but this year we have added the free non-invasive liver health screening to support liver patients and their families and our community. The screening is free, but you must register to participate. In addition to liver health screening, we will have our usual walk and also the same things we've always had, refreshments, music. We're going to make it fun for children, so make a day and come to Santa Monica Beach to stay with us. Our website, liverhealthfoundations.org. On Thursday, August 20th, we will host another educational webinar. This time the topic will be hepatitis B. Please register to attend. We thank our sponsor, GSK Pharmaceuticals, for supporting this. And we will host our best and the biggest event of the year, Salute to Excellence in Liver Care, on October 18 in Los Angeles. In this event, we display educational videos about various forms of liver diseases. We honor liver patients, the best of the best hepatologists, and of course, our nurses. We have posted information on our website, so please visit it so you can buy tickets. There is nothing like early buying ticket, or it's too soon to buy ticket or to sponsor. We are open and we love to have you. Now, we are happy to partner with UCLA. You are invited to attend UCLA's Health's 22nd Annual Patient Symposium on August 29 and learn about liver disease and updates that they have for 2026. The symposium will be held at Ronald Reagan UCLA Medical Center. Free parking will be available. To register, please call 310-206-6705 or visit ucla.in/liver-diseases-2026. Liver Health Foundation will be there with our table, exhibit table, and information for you. And we are also supporting an in-person event sponsored by Madrigal Pharmaceutical on September 10th in Beverly Hills. This is an in-person event. You will learn about MASH with scarring, a treatment called Resdifra. I hope I'm correctly pronouncing it. And you will hear from a MASH patient about her journey through living with MASH. The speaker of the program will be Dr. Jaslene Singh from UCLA. To register, please call 1-888-535-6347. So this brings us to the end of the program. Thank you again to our doctors. Thank you to our audience. We hope the information you received tonight is helpful to you. Wishing peace, freedom, happiness, health, and great summer for all. Good night, take care, and be well.